Welcome to your weekly pulse of wellness. I am your host, Tobi White, a dedicated sport physiotherapist with a passion to helping you move pain-free, healthier, and a more vibrant life. On each episode, we will be speaking about physiotherapy, fitness, and nutrition. We will bring to you science-backed strategies to help you live better, pain-free, and thrive every day. On today's episode, I have Ashade Gabriel, a dedicated sport physiotherapist, specialist in musculoskeletal physiotherapy. Gabriel, can you introduce yourself and share your experience as an MSK clinician?
Okay. Like you said, my name is Gabriel, and I finished from the University of Lagos, University of First Choice and Nation Pride, and also I came to the UK to do my MSc, which I did in sport performance. Then I got a job as a physiotherapist in mental health. Then moved to MSK, which I'm currently in now. And my role as an MSK clinician is basically just to try and help patients to rehabilitate patients, sport injuries, MSK related conditions, basically.
So on today's episode, we will be speaking on knee osteoarthritis. Ashade Gabriel will be explaining what knee osteoarthritis is, how we can manage it, and how we can also prevent it. So let's dive in. What exactly is knee osteoarthritis?
Osteoarthritis. Basically, before I can explain what knee osteoarthritis, I would have to understand what the term osteoarthritis means. Basically, osteoarthritis basically means wear and tear of the joint. The joint. It could happen in any joint. It could happen in the knee, commonly in the knee, hip, and the fingers. Basically, now going back to knee OA, knee osteoarthritis basically is degeneration happening in a joint. Basically, it's caused due to the wear and tear. Now, wear and tear is not the major cause of knee OA. It could happen in even the young and the old. That's why I said wear and tear is not just the major cause of knee OA. So it's part of the factors. It's part of what is causing this knee OA. And we also have people that have previous injury and people that have probably had a fracture related or any injury related to the knee before are most likely to have osteoarthritis in the knee. So now when I'm talking about the knee as a joint and how the knee is being affected by osteoarthritis. Now, the knee generally has two major joints. We have the tibiofemoral and we have the patellofemoral joint. Now, on each of those joints, we have a cartilage. We have a cartilage that's aligned, that is just like a lining on all of those joints. Now, if those cartilage are beginning to wear out on our day-to-day activities, those cartilage have a bit of wearing out, but the body repairs itself. That we don't even feel pain at all. That's normal. But at the point at which those cartilage, the body cannot begin to, repair itself around, and that begins to generate the whole cartilage wears off, and now we have bone to bone. So, and that is what is usually causing the pain. The symptoms attributed are swelling, stiffness that is less than 30 minutes, and pain, especially on walking. Sometimes people will have difficulty going up the stairs or coming down the stairs as well.
Thank you for that insight. So, as a physiotherapist, how can you help prevent or slow down the progression of knee osteoarthritis?
The role of a physiotherapist in knee OA is very vital because we have three categories of arthritis generally. We have we have mild, we have the moderate, and we have the severe one. So for mild, one might even be going about with the mild and not even feel any pain for most of the milds, but some milds will still have a bit of pain. Now, physiotherapy is very useful in this mild and the moderate, in the sense that you strengthening the muscles around, trying to to give a proper advice on load management will help reduce the progression of this condition, and that we can prevent it from getting to the severe stage.
Thank you very much. As a physiotherapist also, how would you assess knee joint? What are the possible tests to diagnose knee OA?
Okay, firstly, if a patient comes into my clinic and say, I'm having pain in my knee, and I think it could be knee osteoarthritis. So the first thing I would want to do is to possibly rule out my red flags. That's the first thing I'll do, basically. Try to ask questions. Firstly, ask questions around your symptoms. What are the kind of pain you're feeling? Is your knee giving way? Is your knee locking? Are you having clicking or clunking or any crepitus sound in the leg? So these are the questions I would want to ask, and I would want to know when do you have the pain the more? Is it when you're at rest? Does it improve with mobility, or does the pain increase more with mobility and get better at rest? So these are the things I would want to know. Another thing I'm going to do in my assessment, like I said before, is to rule out red flags. I want to be sure that it is not anything serious. It is not systemic. It's not cancer. It's not referred pain via cancer, and it's not infection. So these are the major things I would want to rule out. Is this septic arthritis? All of these things are very important to rule out when it comes to assessing my knee conditions. And after then, I would possibly do my my objective assessment, where I would be just doing majorly for my objective assessment. I just do joint line palpation and have a feel of the patella to see if I can feel any crepitus, and also compressing the patella down, to see if there's going to be pain. So these are the minor tests I do to have an overview of what could be wrong with the knee. And one of the major things I would actually also look into, especially in my assessment, is how old is this patient? Is this patient 60 years old? Because also a age-related condition. So how old is this patient? Is this patient 70? Is this, of course, we can have a 35 years old male that has early degenerative osteoarthritis. So, but if a 30 years old comes to me now and say, I'm having knee pain, I would not think osteoarthritis initially if there's no history of trauma, But if an 80 years old man comes to meet me and say, I'm having no history of trauma, didn't have any fall, is a gradual onset and not sudden, and got worse over time, then I might be thinking, okay, yes, this is OA related. So I might not even need to send the person to X-ray, or in fact, knee OA, you don't need to send the person for an imaging until it is necessary. Probably it is at that severe stage to justify, okay, this is surgery is needed, or this is that's when it is needed for you to send. But as a physiotherapist, you want to see, okay, how can I help this person?
How can physiotherapy now help after your assessment? Apparently, your goal is to help the patient, right? How can physiotherapy patients manage knee osteoarthritis flares or maintain independence at home?
Okay, land-based exercise basically is good for knee OA. There's a research around that proves that yes, any exercise that you give to this patient is going to be beneficiary for this patient. So one of the things I'm going to do for the patient is, after identifying their symptoms and trying to understand, okay, these are the things that give them so much pain. Now, I would want to educate them and reassure them on what their condition is, so that they can have a bit of understanding. Is it OA? So I would do a deep, in a layman language, explain what exactly is very important when it comes to patient management, explaining what is happening to them. Oh, I feel this is what I'm feeling. I feel it is OA. Yes, it does not mean it's going to repair itself. You would still be having good time and bad time. Explain what the condition is to them. Explain how it might even get worse over time, and the options they have over time. Is it injection? Is it surgery? Depending on how, if it progressed to the severe stage, try to give them, and also identifying their expectation. If you see a patient and ask them what's your expectation, how is it, their expectation majorly is to identify how, as a physiotherapist, how you can help them. If a patient comes in and say, oh, I was working 30 minutes before, but now I can't even work 15 minutes. So their expectation could be that, oh, I want to be working like 30 minutes, or I want to be able to carry on with my activities of daily living. So these are the things you use as a physiotherapy to draft out your goals for the patient. So it's very important that you explain every of those things that you find out in their condition to the patient. Is very important. Then reassure them that yes, this is it. We will try our best to see how we can keep you going, and even to reduce the progression, because as a physiotherapist, that's part of our role, to reduce the progression of that condition. Now, after then, I'll teach a proper load management technique to the patient. Now, if the patient is working for like 30 minutes and without pain, and from 30 minutes, patients start to feel pain, then this is what I ask them: can you just work for 30 minutes, have a bit of rest, then progress? Especially those times you are having flare-ups. Teach them how to manage their symptoms, because you are not going to be there with them every time. Teach them on how they can manage their symptoms. If, for example, if the knee is being so painful, you can ask them to, if it helps or eyes helps. If it is swollen, you can ask them to put eyes or eat, whichever that helps among these two, because there are some patients that it does not help them, that is eyes that helps, and some patients are cold and not it. So you just try to to identify which one have they used before, and then give them exercise like squats. If they are finding squatting difficult, give them sit to stand. And if they are finding sit to stand difficult, you can give them wall squats, where they can do 1/4 of the squat, yeah, and do knee extension, probably with a TheraBand, to have a bit of resistance, or sandbag, like we usually use in Nigeria. So have a bit of knee flexion and extension. Straight leg raise is also a good exercise. These are the exercises I'm going to give to my patient, depending on those ones they can do that would bring about pain. Now, if a patient is not doing any of this exercise and is bringing so much pain, firstly, I would modify the exercise. I would take it off. I would tell them that any of those exercises that you're doing that is bringing you so much pain, just take it off. Then do those ones that, I know that we are very used to no pain, no gain. Now, but the thing is, if it's giving them so much pain, then they won't be so much effective, especially when it comes to osteoarthritis. There won't be so much benefit in those exercises. So it is very important that we look for an exercise that, like I do advise my patient, do it to, not through the point of pain. So don't do it to that point where you are in pain. You are in pain of 7 VAS, or you are in pain of 10 VAS, or you are in pain that you can tolerate. Yes, depending. I can still tell them, if you can tolerate something, just crack on with what you can do. No rush. Do the little, and with time, you'd see the difference. And it has been working. That's it. So basically, these are the things I would give, and also advise them on footwear. Is very important. If it is getting severe and this thing, then support. Or if it is a severe OA as well, you can refer them to a specialist, where they can do surgery and the rest.
Thank you very much. This has been really insightful. That will be all for on today's episode of Pulse of Wellness.
Please subscribe to our YouTube channel and put on the notification button. Thank you.